put it here. But it's a bit awkward because you can't really see too much. That's what. And diet. Right. A bit of an awkward one because well, my throat is horrendous, as too is my appearance. Anyway, I'm gonna start. Thank God I'm not doing a video today. I sound so congested. It is actually insane. It's gonna be weird if I can do a video like this, isn't it? I'll give it until the intestine. Intestine, blood, and how would I put this? Lumen. It's probably the only way I can really write it because it's still the intestine, but not the cells that you would expect. Give it a couple of seconds and then I'll try it, see what it's like, just a bit of experience. Probably not the best time in the world to talk about cholesterol in your diet, is it? 12 o'clock on a Sunday. Right, but I'm going to start anyway. So, a while ago there used to be a recommendation from dietary guidelines where you had to limit the amount of cholesterol that you were eating because the amount that you eat within your diet would reflect how much is in your blood. However, that has since been debunked, and on average the level or the amount of cholesterol that you have within your diet only translates to 20% of what's in your blood. Right, so this is obviously going to be quite different. So just as a quick one, if you eat foods that have got high cholesterol values, let's pick one. So red meats, you will then have the red meat here, which comes in, gets absorbed across this transporter. If you want it for completeness, it's called Niemann-Pick C1-like 1 transporter. From that point, your body has quite a few checkpoints in terms of seeing whether it needs any more cholesterol within your diet to then put into the blood. So if it finds that it needs to take more cholesterol into the body, what it does is it packages them in the intestinal cells, puts them into something called a chylomicron, and then that goes into your blood and it will go off to your liver through the lymphatic system and sort of gets processed. And this is the reason I'm doing this video is because I work in healthcare, and every single day I will see a patient come in who has high cholesterol. High fibre can help with it, and I'll come on to that now. But the reason I'm coming on to this is because a lot of people who give it health advice on diet, it's very poor. It's normally just medication advice. I'm a pharmacist, so I try and do this first before we go into it. But yeah, so the consensus years ago was if you have 10 eggs, you will absorb all that cholesterol and it will go into your blood cholesterol. That's not the case because of this thing here. So Niemann-Pick C1-like 1 is the transporter that absorbs everything. There is something here called ABC. You can obviously Google all these after this. G5, G8. And this basically goes, how much cholesterol have we got? Let's pump out any excess back into. This is the lumen. So when you think of your gastrointestinal system, it's all a big pipe, it's all a big tube. And it's technically outside your body from your mouth all the way to your anus until it's absorbed across. And that's called the lumen. So someone just said fibre. So one of the ways in which we can reduce cholesterol through your diet is by having fibre. So the most common one, and the one that I would go for anyway, is oats, because oats contain something called beta glucan. And basically if you have 3 grams of that a day, which is about 80 grams rolled oats, what it does is it creates a gelatinous compound within the intestinal system, and basically this red meat or eggs or whatever it is binds to it, and it doesn't allow it to interact with this transporter. If you reduce the amount of interaction, then obviously you get reduced absorption and it comes out the back end, which is obviously good in some instances. But if you are eating too much and you are getting rid of too much, then obviously you'll be on the toilet a bit more. Then your brain will 100% be okay. Right, so other ways in which we can reduce the amount of cholesterol that we absorb. So cholesterol comes under two families. So it's the sterol family. Hopefully you can see this, it's a bit awkward. So you've got sterol, you've got cholesterol, which is mainly animal products. And then you've got something called, you've got plant sterols then. Now, the body will absorb plant sterols into this bit, but it will kick 95% of them out because they're not they are slightly toxic to the body, so we want to get rid of them as much as we can. So when people have a high vegetarian diet, a lot of leafy green veg, etc., it is competing for the same transporter as normal cholesterol. So that is one way in which you can reduce the amount of cholesterol that you do absorb. Obviously, there are many medications, which is obviously one thing that I do, and one of them targets this transporter. Depending on where you are in the world, you may know it by two different names. So there's ezetimibe, which is the actual drug name, and then the brand name, which a lot of Americans know it as, is Zetia, and that just reduces the amount that we absorb. Right, so that is that one. I would just go on to other things that can influence cholesterol, because like I said, the normal advice that I see given out by health professionals is reduce the amount of cheese you eat and reduce the amount of red wine or alcohol that you drink. Obviously, that will influence it. However, it's not going to have a big impact as opposed to having a high fibre diet, which we need to aim for 30 grams each day of fibre. Pardon me, I've got a cold, so I may sound a bit funny. Now, 30 grams a day, do not go up to that if you are on nothing. So if you are having 0 grams of fibre, which is quite common now because a lot of people, especially within the UK and the USA, have ultra processed diets, and a lot of people are having, I think in America it's 70 odd to 80% of their foods from ultra processed sources. You may have heard that term a lot, and basically one of the things that they lack is fibre. And fibre is essential for the microbiome because there are so many things that it does outside of our knowledge that it's obviously better to supply it with the things that it needs. So don't go to 30 grams straight a day. Ramp it up slowly over a period of probably 6 to 12 weeks. The more that you have of fibre, it also competes with this for cholesterol. Obviously, if you're having more fibre, there's less chance of you being able to eat other types of foods because you're going to be more satiated. So that's one big thing for dietary input. The other thing is reducing the amount of saturated fat. So cholesterol within the body, it's quite complex, but saturated fat has a big influence on the amount of cholesterol that we have within our blood. And the reason being is that I will actually remove all this so I can talk about it in another setting. So that was the intestine anyway. Fibre is a good thing to reduce the amount of absorption. That's a big thing. Try and aim for 30 grams a day. Right. Another thing is, so if this is the liver cell, obviously it's called a hepatocyte, there are lots within the body. Now, it has access to a lot of blood, and if you've got cholesterol in the blood, it basically wants to regulate how much cholesterol is within the liver cell. So if you are having a large amount of saturated fat, it basically blunts the ability of the liver to pull this in from the blood. It does normally by putting these things on called LDL receptors. Saturated fat reduces the effectiveness. Obviously this is a very, very simplistic overview, but it reduces the effectiveness there, and it also gives the ability of the body to upregulate cholesterol synthesis. Now, at the very beginning of the live, I did say that if you go and get your blood cholesterol levels checked at any labs, any doctors, you will come out with a value depending on where you are in the world. So let's say your total cholesterol is 5 millimoles per litre. That's what we like to use within Europe. In America, you use milligrams per decilitre, so it's a bit different. I think that would be about, give or take, 200 milligrams per deciliter. Now, where does that come from? What makes that up? So 20% of it comes from your diet because of absorption. The other 80% of it comes from the body actually making it itself. So of this 80%, you can control a massive amount of it if you, how would you put it? If you interfere with the pathway within your body. So long story short, I will go through a quick overview of how cholesterol is made within the body. So we start with a molecule called acetyl-CoA. Now, the reason I'm bringing that up is because this molecule is central to a lot of things. So that can go off and make carbohydrates, it can go off and make protein, and it can also go off and make fats. So when people say, oh, you can't get fat eating protein, carbohydrates, you can, because eventually if there's too much of each individual component, it can be broken down into acetyl-CoA and be stored as fat. So that's why it's so important to know this molecule exists. Now, through a series of reactions, through, I think it's 27 steps, it will go through a couple of enzymes, it will form mevalonate, and then it will eventually go down to cholesterol. So one of the ways in which we can reduce the amount of cholesterol is by reducing the amount of raw materials. Now, where does this come from? Like I said, if you have a lot of carbohydrates, so you've got a diet where you have, and carbohydrates aren't bad, by the way. So for example, if you are an athlete or you are high in activity, so you need a large amount of carbohydrates. So there's a lot of people today doing a London marathon. Then people will have carb loaded last night. They would have stored a lot of sugar as glycogen, and their body will be using that, and that's fine. But the issue is that a lot of people have a lot of confectionery items. They are not moving. They don't have enough muscle mass. And then this carbohydrate, like I said, will then not have any more use, and it needs to be put into this molecule here so that it can be stored as fat. So high carbohydrate diet will give you more acetyl-CoA. High fats, again, same thing. The body likes to use fat as its main energy source. So whilst I'm doing this now, I'm not using sugar. Well, I am, probably about 5%. But the body wants to use fat for two reasons. Because one, we can store it, so we've got a large pool of it, and also it's more energy dense than anything else that we have. The only issue with it is that it just takes a long time to break it down to use. So if you reduce the amount of fat, normally in the form of saturated fats, so saturated fatty acids, they come from things such as, you'll have them in red meats, any animal products really, and then you will have a lot of them within confectionery, ultra processed foods, all them things, the same key offenders. Protein, I would never advise to decrease protein. You should always aim for about 1.6, if I can write it, 1.6 to 2 grams per kilogram each day. People say lean mass. I used to be on that bandwagon, but to be honest, very rarely do people exceed the amount that they need for protein at this moment in time anyway, with the evidence. So the ways to reduce cholesterol synthesis are by reducing the amount of carbohydrates in relation to your energy balance, reducing the amount of fats, mainly saturated fatty acids. Protein, I would always keep on the higher end anyway, because it allows you to build lean mass. So they are the things that you can influence with your diet. Now, this whole process normally kicks in from 12 a.m. to 4 a.m. in the morning. That is when that process of making cholesterol is highest. So if you know someone or yourself, you take a statin and you think you've always been told to take it of an evening, that's because this process is happening at night. So if you've got higher drug levels, there's a good chance you're going to reduce the effects of this later on in the day. That also goes the same for if you can reduce the amount of food that you are eating later on in the evening. Now, I understand there are people who work shifts and there are religious holidays where you are forced to sort of eat within these unsocial hours. However, reduce it as much as possible, because this whole process kicks in around then, because you're meant to be in a fasted state. So if the body can't retrieve it from the diet, it wants to make it itself. And why is cholesterol so important? So there's a few things that, well, I always knew anyway, but there's a few things that I would like to bring up with cholesterol, because there is a relationship with heart disease and cholesterol. I'm a believer of that. There's some people who don't believe in that, but I believe that the studies out there at the moment in time are so, how would you put it, they're unambiguous that cholesterol does cause heart disease. And how it does that is, if you've got your artery here, blood flowing through it, I can't speak, blood flowing through it, if you've got cholesterol and it needs to get out into the body, it can sometimes get trapped into these blood vessel walls. When it gets trapped into there, it then induces an immune response, and then what happens is over time you get loads of cholesterol here, and then it slowly builds out a plaque. So then obviously you've only got this little space here to flow with blood, as opposed to this whole size, and then eventually you starve the heart muscle essentially. So that's where cholesterol comes in. So that's why we always want to control it, but it does have so many benefits that a lot of people overlook it. So one thing about cholesterol is, like I said before, you've got acetyl-CoA, which is the central molecule for fats, proteins, and carbohydrates. So all of them things can be used for energy. However, cholesterol cannot be used for energy. The body cannot break it down. It is a ringed structure. It looks something like this, where it's got so many things to it. The body made it in such a way that even if it's starving, it will not remove cholesterol from the body. And the reason being is that when you have a cell, can be any cell, can be a liver cell, it can be a muscle cell, whatever it is, you have a lot of things in the middle. You've got the nucleus, you've got endoplasmic reticulum, Golgi apparatus, all these things within the middle of the cell. On the outside, you have something called a phospholipid bilayer. You may never have heard of that, but the importance of it is that this bilayer allows it to circulate in the blood and also interact with a lot of things. And cholesterol forms about 40% of this membrane. And it's so important because it allows the cell to be very fluid, and someone just said the writing's the wrong way around. It's not. It's obviously, I'm writing this way. But it causes the cell to be very fluid and interact with other cells around it. So that's why it's essential there. And if you started breaking down that cholesterol away for energy because you were in a starvation mode, then obviously you would kill all these cells. It could be bone cells, whatever it is, and then you wouldn't be able to function. So that's one of the benefits of cholesterol. The other things, as a lot of people now are aware of, because of its structure, if you look at it, I'm not going to draw it here, but let's say it's like this, with a few other things on it, OH. It forms the backbone to many hormones. So you've got, from here, you've got estrogen, I'm spelling it the English way, you've got testosterone, you've got aldosterone, you've got cortisol, you've also got vitamin D, which is a hormone, even though it's classed as a vitamin. All of these have this backbone here, so it's essential that you have cholesterol in enough quantities to be able to supply this. So that's why a lot of people come up with this idea that we shouldn't be lowering cholesterol too much. However, when we measure cholesterol on your blood test, it's the levels in your blood, not the levels within your cell, because this is the next thing. It's so important that every single cell in the body can make its own cholesterol, apart from mature red blood cells, because they lose a nucleus once they've matured, basically. So it's vital for hormonal health, it's vital for cellular health. Another thing it's so vital for, I'm just giving a bit of context that I obviously want people to reduce the amount of, it's not just cholesterol that's causing heart disease, but it's a big factor of it. It's like saying, I don't know, fire burning wood is the cause of the fire. Obviously there's many things that go into it. There's the actual flame, there's petrol to maybe start the fire, there's so many things that go into it. So cholesterol is not the only thing. There's inflammation, there's insulin resistance, but it's a big component of it. Now, if you think about me writing this now, so I'll click on my fingers, that's a thought in my brain coming through all the nerves to click the fingers. When you've got, let's say this is the brain, square brain, when you want to do something, so the output here is to click the fingers. I'm just going to put the fingers there. To get along this, depending on where it's originated, you've got to go through loads of nerves. Now, the way in which we can do it near enough instantly is because we have these things that coat the nerves called the myelin sheath. So basically when you think of something and you want an action, it doesn't travel in a straight line, it travels like this. It's called saltatory conduction if you want to look into it. However, the reason why that's so essential is that it cuts down the time for your response from a nerve, and cholesterol forms a lot of this myelin sheath. So again, another reason why cholesterol is so important, and that obviously I want people to reduce their chance of heart disease, but I don't want them to completely demonise cholesterol and be scared of it, because it is so useful in enough quantities. The only diet needed is a plant-based diet. Why are health and... So a lot of people ask, so plant-based diet, obviously my diet for anyone, so I'm an omnivore, eat everything. However, the large majority of my meals I would say are plant-based. So my breakfast is largely plant-based. Sometimes I have it completely vegan, sometimes I have it without. The only issue that I would say with plant-based diets for a lot of people, so I'm not saying it yourself, is that a lot of the foods that people have normally have ultra-processed ingredients within it. And when it comes to meeting certain vitamin requirements, yes, you can have a non-nutritional deficiency diet with a plant-based diet. I've got a lot of patients who are fine. However, a lot of people struggle to get B12, iron, and a few other things because in a plant-based format, they aren't as bioavailable. So, but yeah, plant-based diets do have a lot of evidence for it. When it comes to sports, there was a famous Netflix documentary, I think it was on an NFL team. I cannot think of who they were. Don't know whether it was the Miami Dolphins or something like that. And basically, they put all them through testing. They put them on a plant-based diet, and their results, if anything, went through the roof. The one thing I would say about plant-based diets, if you do it well, is that it's the same with most diets. If you go into it and have whole foods, then I feel like you get a large benefit anyway. But yeah, cholesterol. I bring up cholesterol quite a lot because it forms a lot of my consultations, because as a lot of people know, the first line of defence is high cholesterol and we put you on a statin. Well, that's what a lot of people do anyway. But that's why I've started doing a bit more educational stuff for healthcare professionals, because there are so many things that we can do before we need medication to then intervene, and so on. So where was I up to? So that's why cholesterol is so important. And the next thing I want to say, so diet, we've just said then saturated fatty acids, carbohydrate intake, if you can lower that or at least meet it to your demands. If you are from America or you follow dietary guidelines, the one thing that I don't understand is that the American Dietary Association, they've just released new guidelines, I think it was 6 months ago, and they wanted all saturated fatty acids they basically done a pyramid, and a lot of their recommendations with dairy, which I don't have because I'm lactose intolerant, they had red meat, they had, there were so many things that were all animal based, and I feel as though a lot of that is due to deals, but I'm not going to go into that further. One of the recommendations they still have is that saturated fats should not exceed 10%. However, if you are following the diet that they've just advised, that is near enough impossible. So I don't know how that's going to happen. But, so you reduce that thing, you have meal timing. Early on in the day is obviously better due to circadian rhythm, which I'll come on to in a second. And one of the other things that a lot of people overlook is the involvement of insulin within cholesterol synthesis and health in general. So a lot of people have heard of insulin resistance, and it's been highly simplified to the point where people say, oh, it's just where your body is not listening to insulin. That is a very, very simplified way. It starts within the muscle, liver, so on and so forth. I'm not going to go into the mechanics of it, but one thing is, if you have insulin resistance, one thing that happens is that we produce a lot of insulin to try and combat it, because the body, like a lot of things in life, if something doesn't work, you normally just keep spamming it until it overrides. There's always an override function on everything in life, and that's no different for your body. So I just wanted to include this just for a lot of people who may be saying that they don't have insulin resistance or they're not classed as diabetic yet and they're unsure of how it would ever fit in. So I understand that this is back what someone said, but let's just do this quick graph. So we have insulin on this axis, and we have, what would we have? Time here. Right, so let's say I have a meal at point 0 here, and I am a normal person, let's say. So this is what would happen with the insulin. I'm also going to do glucose, but glucose is going to be a dashed line. So after a meal, you would expect glucose to go up and then eventually come down to a baseline. At the same time, you would expect insulin to go up and then slowly come down. And that should be proportional. They should always have a relationship where you think, okay, that's a reasonable outcome. However, when you become insulin resistant, this is what happens in a normal person. Your insulin resistant person goes up, goes down. You are still keeping the same amount of glucose within the system and the same amount of blood. So if you were to do a finger prick test or go and get a blood test, your level, depending on where you are in the world, might come back at 6 millimoles per litre. But the thing that we don't measure is how much insulin has been required to make that change. So eventually what happens is the amount of insulin that you release will eventually be exhausting your body's stores. So that's a general overview of insulin resistance. And why I bring this up with regards to cholesterol is for the following reason. So now that you understand that we secrete more insulin to try and override the system, then this pathway before I showed you, so you've got acetyl-CoA. This is a very simplified how cholesterol is made. It goes to mevalonate. If you want to really go into too details, there are two pathways from this point where it goes down the lithostrol and desmostrol pathways, doesn't matter. And then we come to cholesterol. Now, in this step here, there is a massive enzyme that works. It's called HMG-CoA reductase. Now, this enzyme or this step in the whole process is pivotal because it is the slowest step within the whole process. And why that's so pivotal is if you affect the slowest part of any process, it becomes the rate limiting step. It becomes the most pivotal. So this is where a lot of medications, so this is where statins work. They inhibit this enzyme. If you inhibit this, you don't get any of this and you get a reduction in that. So that's a big thing there. However, when you've got high levels of insulin, so hyperinsulinemia due to insulin resistance, this enzyme here is increased. So high levels of insulin increase this enzyme. So then you get the inverse, you get increased mevalonate, increased cholesterol, and then it goes on, so forth. So that is why you can see how all these things interfere with one another. And I obviously think I put more focus onto insulin resistance going forward because of how pivotal it is. So that is when I've got a better voice. So hopefully tomorrow or the day after, that is what I will be doing, is doing a video on how statins work and how cholesterol is made so that people have a good baseline. And then from that point, I can come back with dietary things, I can come back with medication, whatever it is that people feel like they need to know. So let me see. Bad cholesterol, okay. B12 is 224, okay. So I'll go through bad cholesterol now. It's a good time to go through it once I have a sip of this coffee. So like I said at the beginning, what cholesterol is this molecule. I can't even draw it. It's got loads of stuff on it, hydroxyl groups, whatever. That's cholesterol. That remains the same all the time in your body. But obviously you have people say good and bad cholesterol. You have a lot of healthcare professionals say it, and I feel it's obviously to make it more user friendly for the patients. However, I do actually believe that a lot of professionals don't know what it is. So that stays the same, cholesterol. However, because it's a fat, if you ever go and put olive oil within water, you will notice that they do not disperse within one another. It becomes little globules and basically it just doesn't mix because fats do not mix with water because of something called hydrophobicity. Cholesterol is still the same because it's predominantly fat. It needs to be transported in the blood attached to something. So from now on, we're going to call this picture is just going to be a C, cholesterol, like that. Now, this cholesterol, to go into the blood, it needs to have something that's soluble and dissolves within water to take it around the body. And this is called a lipoprotein. And this is where the good and bad cholesterol comes from. So these lipoproteins have loads of different names. So you've got very low density lipoprotein, VLDL. You have low density lipoprotein. You have intermediate density lipoprotein, and you have high density lipoprotein. They're the four main ones. Now, LDL and HDL are known as bad and good respectively. Pardon me. The reason being is that, I will come on to this, I'll draw it from the liver, just so that you can see. So bear in mind, this cholesterol has still stayed the same, it's just that it's being transported in a different way. It's like saying a person is bad if they get a taxi from somewhere, and they are good if they get a bus from somewhere else. That is the same analogy that I'm going to use. So this is your liver. Looks a bit funny. When the liver puts out cholesterol, it puts it out into VLDL, and it puts it out into LDL particles, and that goes into the blood, like I said, in this transporter. They go off to muscle cells, they go off to fat cells, all the other cells in the body. And then when the body wants to recuperate cholesterol, it comes back in a HDL. So that's why it's known as bad, because it's got more chance to put it within the artery walls, whereas good if it can take it away from the artery walls. So that's where good and bad comes from. But they actually have, it's the same thing. Cholesterol is the same. There's no such thing as good and bad cholesterol. It just is being transported in a completely different way. So that is why I don't use them phrases anymore to any patients, because it completely confuses them, and then it gives people a completely different outlook on it. Thank you very much. So let's see, how are we doing? I'm good, thanks. If insulin, the hormone responsible for lowering blood sugar, why does a person with insulin resistance often have high levels of both glucose and insulin in their blood at the same time? Okay, good question. Right, I am actually going to go into a bit more complexity here. So the way in which insulin works is, so we've got a cell here. Let's say this is muscle. Insulin has a receptor here, insulin receptor. Once insulin comes in, so that's this one, once it binds to here, it will then bring these little channels up to the top, and it puts them in the membrane so that glucose can come in. That's how glucose comes into a cell. So that's the main way. So without that, most cells in the body can't use glucose. There are some, so the liver can use it, the muscle and the brain can use glucose without the need for insulin, but it's not as effective. So that's what normally happens with insulin. However, insulin resistance is a very, very funny thing. Insulin resistance normally starts because you've got too much fat within a muscle cell or a liver cell. So how would I put this now? I'm trying to think about it in the best way to explain it. So it's all to do with energy balance. So like I said before, you have, I'm trying to do this without being too convoluted. Because essentially what happens is, why you have high levels of insulin and high levels of glucose, is the end result is your muscle stops to listen first, and then it goes onto the liver, and the liver can do something called gluconeogenesis, which stands for the new production of glucose. And when the liver's not responding, you've got high levels of insulin, and then you've got the liver outputting more glucose because it's not able to get the sugar within a cell anyway. So you've got high blood sugar, you've got high levels of insulin, and that's how they both coincide. So I'm going to have to explain it. Here's the insulin receptor on a membrane. This is inside the cell here. When insulin binds, it has a few little things that happen. So there's insulin receptor substrate. This needs to be activated through a phosphate group. This will then go through more activation to PI3 kinase, and eventually it will form these GLUT4 transporters to go up to the membrane and let the glucose in, like I've just said then. And then glucose can come in and your blood sugar will reduce. Pardon me, I've got a cold. So that's what happens normally. Now, when you have someone who's got insulin resistance, normally insulin resistance is caused by a lot of fat within the cell. So like I said before, carbohydrates can, if they're not being used, go to a molecule called acetyl-CoA. That will eventually, if it's not being used, go to fat. Now the body likes to store fat wherever. So that is one thing. But like I said before, the muscle cell likes to use fat as its main energy source. So let's say you've got fat coming in, and people have heard of the mitochondria. So that's where something called beta oxidation happens for the body to use fat as energy. And we want to use that because fat has so much more density of energy. It is just a lot better to use. So that's what normally happens in a normal person. If you go to the gym, your body uses fat up until a level and the best energy in return. So what happens is if you get too much fat in the cell, it then blocks this process here. It blocks the activation of this IRS phosphate group, which then prevents these from being put on the membrane, which then leads to more sugar in your blood. And you go, okay, like I showed you before, there was this graph where insulin's normally like that. It will go up even more to compensate for that increase in blood sugar. And that will eventually override it. So, like I said, a lot of things can be overridden. So eventually that works. However, there comes a point where no matter how much insulin you release or you exhaust the stores of it in your pancreas, that we cannot get this sugar into the cell. Now, there's two things that happens. Because your body's got a high blood glucose, your body also thinks that we don't have enough energy within the body because it's not getting it into the cell. So what happens is then the liver starts producing more sugar because it thinks it needs more energy. And that's where it becomes an issue then, because you've got high levels of insulin, you've got high levels of sugar, the liver's starting to output more sugar. It's not then allowing glucagon to work, which is the opposite hormone. And that is how you start a massive cascade of events. Now, I will come on to the questions now, but there's no good in me telling you about insulin resistance and all the bad things about it if I don't tell you how to fix it. Now, there are medications. That is my last resort with anything, even though I prescribe. Last resort. Best ways to improve insulin resistance are improving muscle mass. If you improve muscle mass, you give yourself more places to store sugar, to store fat, so you have a bigger reservoir to utilize essentially. The next thing is to do something called increase in zone 2. So like I said then, the mitochondria, where beta oxidation works, is all improved via zone 2. And zone 2 is where you are doing steady state work. So that is a brisk walk where you can still exercise and have a conversation, but you're quite out of breath. If you do that, you improve the function of the mitochondria, which means if you have loads of fat coming in, it's not being stored, it's being used, which then reduces your chance of insulin resistance. And then the next thing, as with a lot of things, is if you reduce the amount of carbohydrates and fats, mainly saturated, then you give yourself less energy in the body to be stored as fat. They're the main ways to improve insulin resistance. It's not rocket science. If you want to go down the pardon me, you want to go down the medication route, obviously GLP-1s are working because they are reducing weight. You have got metformin, you have pioglitazone, you have SGLT2 inhibitors, SGLT2. So they're the ways that you can do it if you want to go pharmacologically. Right, so that's that one. Now, he goes off lab versus normal. I asked him and said it's hard to explain. Then he doesn't exactly, a lot of people. My lab B12 is normal, but psychiatrist low. Yeah, B12 is one of the things. So a lot of people actually don't have a lot of low B12. They have something called a lack of intrinsic factor. So basically, when you have B12, a lot of it comes from leafy green veg, comes from a lot of red meats. So when B12 comes into the stomach and then goes into the intestine, it needs to bind with something called intrinsic factor, which is made in the stomach. Now, if B12 is not bound to intrinsic factor, your body will not absorb it. So that is something called pernicious anemia. So you can get blood tested for that. You can see if you've got antibodies, but it's all to do with treating the patient. Some patients may have a better response to lower levels of B12. Some people have a better response to higher, but I normally aim for about 400 or 500 is where I normally sit. Are B12 injections good? What do they actually do? So where I've just said then that you need intrinsic factor within the intestinal system to absorb it, B12, because you are injecting B12 into the muscle, so it's normally the shoulder muscle. It goes into the bloodstream and it doesn't have to go through first pass metabolism, which is by the liver, so you don't have to worry about that. So a lot of people who have a lack of intrinsic factor normally go on B12 injections for life. Depending on the reason why you've got on it, it'll be every 3 months or every 2 months if you've got some neurological involvement. Pardon me. Mediterranean diet's good. Obviously, it's got a lot of healthy fats in it, if you want to say that. Thank you very much. Is insulin resistance the cause of type 2 diabetes, or is it a symptom of something else? Type 2, yeah, so it's always one of them things. So insulin resistance is the reason as to why you have high levels of insulin. So they always say for type 2 diabetics, they probably had a high level of insulin, hyperinsulinemia, for about 10 years before they're clinically diagnosed. So type 2 diabetes, in the large majority of cases, by the way, there's obviously a few patients who do not fit this, but it's mainly due to energy abundance. And it's obviously because the diets that we have now, we've never lived in society where we've had more energy than what we can expend. Obviously throughout human history, we've only ever had enough energy to basically supply what we need to do, whereas now we are finding ways to store energy, and that is why, yeah, it's obviously detrimental for us. With type 2 diabetes though, I'll go back to the question. Insulin resistance is the cause, in my opinion, of type 2 diabetes, which then leads to hyperinsulinemia. So like I said before, if insulin is not working on the receptor, the body will increase the amount of insulin released. Insulin is stored within the beta cells of the islets of Langerhans. I spelled that wrong actually. It's in the beta cells of the islets of Langerhans, right? Obviously there is so much that we can supply. However, once you exhaust this supply, you then can't even supply the insulin to combat the insulin resistance. So then you just have a massive increase within your blood glucose. So insulin resistance is the biggest cause, and there's a lot of theories out there. So depending on how interested you are and how deep you want to go into these things, there is I don't know whether he's a biochemist actually. He's quite a famous one. He's called Gerald Schulman, and he come up with the insulin resistance within muscle cells theory, and he's got a lot of advice and a lot of evidence to prove it, because there are, how would you put it, I always try and tell people that diabetes is not a disease of sugar, it's a disease of fat mismanagement. And the reason being is that, like I said, if you have too much fat in your muscle, you will eventually get insulin resistance. If it's in the liver, you will obviously get insulin resistance, but at the expense of also having increased glucose production from the liver. If you have too much fat within the pancreas, you can then change the formation of these beta cells, and they basically don't know what they're doing. That is probably the simplest way of doing it. And this was all backed by a study done in 2008. There was a Scottish professor, and I can't think of the other person. Anyway, his name was Rob Taylor, and he came up with something called the twin cycle theory. And this was a study that sort of revolutionised diabetes management. However, it was never uptaken properly within the NHS and other health systems. But they took, I can't think of how many patients, but they took 2 groups of patients who had type 2 diabetes, and they put one on a normal diet, so the placebo control group, and they put other people on an 800 calorie a day diet. I want to say it's for 12 weeks. I haven't read the study for a while, but basically they reversed the large majority of type 2 diabetes within that cohort. And the reason being is because when you are reducing the amount of energy that you eat, you then need to use up your energy stores, which is obviously fat. That's our predominant storage. It then pulls the fat out of muscle, out of the liver, out of the pancreas, gives you back insulin sensitivity, gives you back the function of your beta cells, reduces the need for your liver to produce glucose, and then you obviously improve in a lot of other functions. So that's when Cycle Theory come out in 2008, and they done a lot of follow-ups with it, and that is why I started changing the way I approach patients with regards to diabetes, because this is the other thing that gets me, is if you have a blood glucose level and we give insulin, it will always reduce it. But I always do it as the case of, if this is a cell and you've got all this as fat, let's say, if you have insulin given as an injection, which obviously it's got to be, it can't go through the stomach, it will then override this and it will force more sugar to go into there, blah blah blah. However, if you reduce the amount of energy and pull all this out, all the fat out, it will then allow that cell to work properly, and then that's when you have the best outcomes with it. So that's why I go down that route first. But from a numbers game, it's obviously insulin is going to be very effective from a numbers game to lower your blood sugar, but that's why I always tell people. Yeah, I know. I don't know how I'm going to reverse. Let me see if... Let's see if I do it this way, but I won't be able to see the questions. Okay. I'm going to have to do it like this, but I won't be able to see questions. Alright. Let's see. Yeah, that's the best way. So, let's see. So I'm in the middle of a plant-based health fitness. Okay. It won't be this year. I'm back. That's really good. Yeah, so, right. Obviously, I'll check back every couple of seconds. I'm just seeing if I can see that. Okay, I can. Plant-based is obviously very good. Like I said, the only issue with plant-based foods for a large majority of people, this is not for everyone, is that they normally go for foods which are substitutes for the actual thing. So they'll go for like vegan sausages where it's got certain components in that aren't as healthy as just actually having a vegan diet. But there are a lot of things for it, and like I said, with regards to cholesterol and all these other things in terms of reducing inflammation, if you go for plant-based and you go for whole foods, it's the same with any whole food diet. You are going to have a really good return on your health, because all these ultra processed foods, we actually don't have many at all, to be honest. No, just water's really. Hummus. Yeah, we don't really have much. I probably have about 5% ultra processed foods in my diet, but they contain stuff like emulsifiers, they have thickeners, they've got rapeseed oil, etc. There's a lot of things in them that obviously are going to disturb your body in such a bad way. So let me see if there's any questions before I carry on. Before I go on to the next thing. So, I want to see that. It won't be this year. Yeah, can it be the cause of medications not working? So B12 is essential for nerve function. That's the biggest thing normally when you have the development of a baby's neural function. But B12's usually used in nerves. That's why a lot of people who have low B12 get diagnosed when they have paresthesia, which is pins and needles basically within the hands and feet. So B12 is essential for that. I mean, any nutrients, if you're deficient in anything, you're obviously depriving your body from being its most efficient. So that is one thing. In terms of, do you need to supplement? If you've got a full balanced diet and you've got no symptoms, I don't think you really need to. But that's what a lot of people that is one of the vitamins, like I said before, with plant-based. So I'm lactose intolerant, so it's basically the same as being plant-based when it comes to certain vitamins. So the ones that always give me concern are B12, you've got B9, which is folate. Well, I'm not the best with vitamins and health. You have calcium. These are like the ones where I always think, iron. What else is it where plant-based or lactose people may struggle? Pardon me. I'd say they're the main ones. And then a lot of people, if they can't obtain it from the diet, like I said earlier, you can get something called fortified foods. Now this is ultra processing, and that is probably the only small percentage that I have, is that most of these for me are covered by oat milk that I have in my coffee. So that's basically as much processing I get. But they're the only things. There's a lot of factors. Again, we obviously discuss things as blanket advice and guidance. However, one person's individual body is completely different to someone else's. There's 8 billion people on the planet. We're not going to have the same biochemical structure and function. Right, what else was I going to discuss on this? So insulin resistance. I'm going to actually do a full video on that. I bought this today and I thought it was going to be bigger, to be honest. So that's why I'm holding it like this. So it's a bit of a pain. But we move on. I'm not going to hold it against me. But what was the last thing I wanted to talk about before I went and done something? Oh yeah, so the other video I'm going to do, unless there's any full questions, maybe I'll have a quick look. Veg. Oh wow. Okay. Well, that's where obviously, I mean, there's obviously Eskimos where they just have meat, there's no veg and stuff like that, so there's a lot of ways you can get around stuff. 1 second, I've just had a knock. Don't know who from. Oh, 1 sec. I'm just doing this. Right, so triglycerides and cholesterol, are they linked? Yes. Right, I'm going to go on to it. So triglycerides are, you've got glycerol, which is, I'm going to draw, so glycerol, and then you have 3 fatty acids attached to it. So that's a triglyceride, tri being 3, glyceride, glycerol plus fatty acid. Why these are essential is that when they go into the body, they go into a cell, we then break them up into individual fatty acids. That can go into the mitochondria, like I said earlier, and it can do beta oxidation. So it's the storage form of fats. Now, what the issue is if you have a high carbohydrate diet, the best way to control your triglycerides, and there's a bit of complexity to it, is when we check your blood levels, we're obviously looking for the cholesterol and triglycerides within your blood at that moment in time. That's why we normally say to have it fasted, because if you have a meal, within the first hour, your body is mainly transporting triglycerides around your body. They will eventually drop, okay? Did you know I was on this?
No.
Oh. They will normally drop quite quickly, within an hour to 2 hours. Now, if you are someone who's really active and is really good, can you see? No one there?
Yeah.
If you're someone who's really active, having high triglycerides is not really that much of a concern. It is for the large majority of people because it's a sign of pancreatitis potentially, but for a lot of people, if you are highly active, triglycerides being high in your blood means that you are just using a lot more fats and you're going to use that energy. But that is one way around it. So if you are having a lot of carbohydrates in your diet, like I said before, carbohydrates go off within the body to make ATP. That is the energy currency of every cell. That is how we use energy from food, because we don't release it all at once because it would just be inefficient. If you do not use that carbohydrate and it doesn't go to ATP, it will go to glycogen, which is in muscles. So a lot of people, for example, if you were to fast for 24 hours, 24 to 48 hours, and people say, oh, I've lost a couple of pounds, that's normally because you've lost the glycogen that's in your muscle and the water that's associated with that. So that's the first bit of weight you lose. If you are not using, or you've got enough for glycogen and you've used all the energy from the carbohydrates and you still have some left over, it will be broken down to that molecule I keep bringing up, which is acetyl coenzyme A. Now, like I said before, this can then go off when it's in excess and be built up into fats. And the first thing is that it will also, so fats, it will be increasing the amount of triglycerides, and that is one way to reduce it, is by matching your carbohydrate intake to your energy output, because that will reduce it. In terms of how does cholesterol and triglycerides and all these things interlink with each other. So when your liver, I'm going to do as a square, so your liver puts out cholesterol, it puts it into these transporters like I said before, and it'll have cholesterol in there, so I'm going to do loads of C, whatever, and then it will also put triglycerides in there. Now if you have so many triglycerides, it will then have to make, well, I'm not going to say twice as many because there's not an arbitrary amount, but it will have to make more of these transporters for the same amount of cholesterol to make sure that you get it out there. So why this is an issue is that you have more of these particles in your blood, and they've got more chance to be lodged in to cause the plaque, which leads to, or is a factor within heart attacks, heart disease, strokes. So that is how they link. Now I'm going to have a quick check if any questions are there, because I can't see anything. Right, so, yeah, is there any?
So do you know NICE guideline 239? So I'm guessing is that to do with hypercholesterolemia maybe? I don't know off the top of my head.
Let's have a look. What's the other one? So there was one, someone asked me this question up here. So, anonymous, okay. NICE guideline 239, do you know?
I'm guessing that's probably lipid management, I think it is.
Did it say B12?
Oh, B12. Oh, okay.
Pardon me. Do I know NICE guideline 239? To a decent extent. Obviously, I was picking up very quickly, but in terms of, is there anything in particular that you want me to go through?
Would B12.
But B12 deficiency, you can treat it in two different ways. You can have asymptomatic B12 deficiency, or you can have B12 with symptoms. And there's actually, I don't think it's on NICE guideline, it's on another clinical guideline. You have 4 ways in which you would treat. How would you manage someone who's come in for the B12? Stand back a bit.
Yeah.
So if B12 is normal and no symptoms, you don't treat. Yeah. If B12 is low, and again no symptoms, you can treat. If B12 again is low and you have symptoms, you treat. If B12 is normal but you have symptoms, this is the other one, you can actually treat on that one. But
so you said my level is 244. My doctor said lab normal. My psychiatrist says that's really low and needs to be over 500 to 800 to be put on injections for 6 weeks. Do you have symptoms? That might be why. Also, what's the level? Is it 300? Is it that we?
Well, it depends. Some labs say, so with B12, there's different lab cut-offs. So a lot of people say about 180 plus. 180, then there's some labs where they'll have 200. But if you go above that, that is when you would consider to have a normal B12. Now, psychiatry with B12 comes into it comes into another category, because if you have something, you can type it in, you can type in B12, BNF, whatever you want to go on, and it'll say there's 2 different indications for B12. There's a few actually, but for injections you have got the 3 month and you've got the 2 month. The 2 month is where you have neurological symptoms. So these are normally, like I said before, it's normally to do with maybe slight cognitive impairment. It's normally paresthesia, so pins and needles, all these things. You will go on a loading regime, which is every other day, I believe, top of my head.
Yeah.
Every other day, and then you go to 2 monthly injections. And then with the 3 month, you load up, and then you have it every 3 months, and that is just for general B12 deficiency. You would normally go on these pathways if you have low intrinsic factor, so they should be looking at intrinsic factor, because you don't need that when you have an injection. There are tablets which we don't really use because they're not licensed, because the evidence isn't the best. But yeah, that is that.
Yeah, you said that a psychiatrist says that it's key for mental health and medication effectiveness.
Yeah, obviously a lot of medications can affect B12. One off the top of my head, which is a massive one. What were you going to say?
Metformin.
Well, yeah, so you've got metformin, they affect B12. Omeprazole, or PPIs. And someone's actually writing a plant-based book on fitness. That is one thing that I would look into for the plant-based book, because a lot of people have diets, normally ultra-processed, which are increasing acid. So if you can reduce that, reduce the weight, there's no need for you to have that medication in a lot of cases. It is the most, is in the top 5 prescribed drugs.
I think it's like second or
Pardon me. There you go.
2 months.
Oh.
Yeah, well, I thought you were doing that now.
What time is it?
It's
Oh,
1,
cool.
so
Okay, and then what are you doing?
taking how gymnastics, so I'll be back later.
What time are you staying up now?
Yeah.
So you'll be back about 4:30ish?
Yeah.
Okay, see you soon. Right, so that's the thing. I will be looking at the questions in between as well, so bear with me. B12. Right, I think mine's down. It's a poor diet. Yeah. But this is the thing, so I'm going to touch upon the plant-based as well, because one thing that I find a lot of is, and we've not discussed it today properly, is iron. So when you are on a plant-based diet, mine was actually fine. So you've got 2 forms of iron. So you've got heme and you have non-heme. So non-heme is what we get from plant-based sources. Heme is what we get from animal products. Now, in terms of which is more readily absorbed, heme, animal-based products are normally better when it comes to these things. So we absorb, I think it's got an 8 to 10% absorption. And non-heme, there's a big overlap here, by the way. I think it's 8 to 18%. So a lot of people do not have enough iron within the diet to actually counteract what they're losing. So obviously women have to have a higher level than men because they have monthly menstruations. A lot of people who have a lot of trauma need to have higher levels of iron. Now, the thing I would say is there's obviously ways in which you can improve iron absorption, and iron is one of the things that I see the most within daily clinics. However, it's probably one of the most overlooked and most complex things, because you've got loads of blood tests, so you may look at your iron levels on a full blood count, but this is the last resort, so you look at hemoglobin. So for men, we want it above 130, and for women, we want it above 120. But this is called iron deficiency anemia. So this is the last resort. So iron is that low in your body that you are developing anemia due to it. There are things that we can do before then, so they are called iron studies. And what these look for, so the biggest one that people may be aware of is something called ferritin. And this is the amount of iron that we store within the body. And it's the first place I look for. So if this is normal, so you've got a normal hemoglobin, a lot of doctors will say, oh, that's fine, you can carry on. You can have a normal hemoglobin, but you can have iron deficiency. It's just not anemia. And then you can still have symptoms of weakness, tiredness, pardon me. So always look at ferritin, because a lot of people use a cutoff of like 20 and above is fine. I would say 50 is what it should be as a minimum. But you need to be aware of if you are having a blood test and you are unwell. So for example, me the last 2 days with a cough and cold, if I were to have my ferritin, it would likely be higher because we use ferritin. It's called an acute phase protein. But basically, when you have an immune response, we release more of this. Oh, I think it's due to iron is actually toxic in certain forms to the body. So we want to try and get as much of it out of the body as possible. Right. That was a bit of a detour anyway, because we were talking about plant-based and stuff. Let me see if there's any other questions. Pardon me. Yeah, you can ask a question. So, should I worry if my doctor said bad cholesterol? Like I said before, so this was the whole point, cholesterol. If you've got bad cholesterol, which is not a term that exists, it just means that you have a higher level of something called LDL, which is low density lipoprotein. And what does that mean? It means that you've got more cholesterol in a ship, in a cargo, in a transporter that is going towards your blood vessel and other tissues. Like I said, if you've got cholesterol in these LDL particles, they need to get out of the bloodstream to interact with whatever cell they're delivering the cholesterol to. When they are getting on their way out of the cell, they go through the wall of your artery. So, I mean, in there, so the vein there, they need to cross that wall to get into these other cells to interact with them. Now, on that way out, it can get trapped in there. There are a lot of things you can look into, but there's the main thing that it gets trapped to is something called proteoglycans. When it gets trapped in there, they will stay there. And because it's not meant to be there, you will get your immune system kicking. So you'll get something called macrophages. They come in and basically they will try and engulf it. It gets too big and then it starts this immune response where you have a clot that can start to form. And if that breaks off and goes to your heart or brain, you obviously then lead to a stroke. However, with cholesterol, it is not the only thing that causes it to build up. So like I've just said then, it just means that you've got a high amount of these particles going through your blood. This is all your blood now. However, for you to have things trapped within the wall, I'm going to do this as the wall, for them to get trapped into there, a few things happen or need to happen as well. So this lining needs to be damaged. Things that can damage that wall are smoking. You've got high blood pressure. You also have, I mean, I'm going to say ultra processed food, but anything that's poor in dietary sort of substance, all these things can damage that. You've also got other things that can cause dysfunction here, and it's a reduction in nitric oxide. So people may know nitrous oxide as laughing gas, or yeah, we'll do it as that. Or people who have a spray for underneath the tongue if they've had a heart attack, it causes your arteries to completely dilate, so they would expand twice the size, which is what we want. If it's not, then you're going to have more damage due to your blood pressure. So they're all things that contribute to that. If you also have a diet, so UPF, if you've got a diet that is also high in omega-6 and 9 and low in omega-3, your body is more predisposed to making pro-inflammatory molecules. So it doesn't say that you are actively inflamed, which is a lot of people say that to try and get people to buy stuff. It doesn't mean you have active inflammation. It just means if something were to happen, then there's a good chance it's going to go down south very quickly. So if you reverse all this and lower your cholesterol, you reduce that risk. But having a high level of LDL cholesterol on its own is not it's not a factor that's going to cause you to have a heart attack. There are people who have seriously high levels of this, however, they manage all these things, and they never have a heart attack. And that is where, in my opinion, that's where the cholesterol myth comes from, is that there's a lot of people who are centenarians, so people who live to 100, and basically they have high levels of cholesterol, which it will increase as we get older, which I will tell you in a minute why, but they have high levels of that. However, they have reduction in stress because they live in certain environments, normally Mediterraneans actually, and because they've got low risk and everything else, they're a good weight, they're active, they're healthy, then they never have a heart attack because it's all combating it against it. Now let me see. So, issues. I welcome any question, so that's fine. With regards to my personal history, so if anyone wants to know, I'm going to get rid of this cholesterol now. I'm also going to get a water. So if you give me a second. Wow. I've had sore throat and congestion for about 3 days, and then I woke up this morning and then it was a bit better. Last night was actually quite... The plan today actually was to go and buy this whiteboard, which I thought was a bit bigger, do a few videos on YouTube, and then, yeah, obviously that didn't go to plan because this is absolutely tiny. However, it's doing the job to some degree. Right, so with me, for anyone who doesn't know, so what do you call it? I mean, from a personal health point of view, I have a condition called wow, that was horrendous. I've got GCK MODY, which stands for glucokinase modified maturity onset diabetes in the young. So I've got diabetes, but it is a very rare. It is the only one that I know of where you actively do not need any treatment at this moment in time, and your risks of complications. So the complications with anyone who has diabetes, which I don't want to scare anyone, but I always want people to understand that because everyone has diabetes, it doesn't make it any less of a disease or condition. Diabetes, in my opinion, is probably one of the worst conditions on the planet because it reduces your life expectancy still by up to 10 years, even with good medical management, and it gives you such a high risk for every other condition. So risks of complications are kidney damage. I'm going to do them words. If you want the fancy word, it's nephropathy. You have eye damage. I'm not going to do damage because you know. So that's retinopathy. You have cardiovascular disease. So they are heart attacks and strokes because of the way glucose and high levels of insulin can interfere with your blood vessels, so it increases the risk that way. You also have nerve damage. So a lot of people who are diabetic, you will see them, you've got to have a foot check every year. So all these are covered. So you have blood tests every year for your kidney, you have an eye screening every year, your cardiovascular disease. It's probably actually not looked at enough in my opinion, but it's covered by a lot of blood tests. Nerve damage is covered mainly by a foot exam every year, and the reason being is that a lot of diabetics will find themselves to have something called diabetic foot, and it's a very severe condition actually. So if you think about it, if you think of your feet, because your feet are here, your heart's here, blood flow isn't the best. So when you are damaging the nerves, you are then reducing sensation. A lot of diabetic patients then walk around with stones in the shoes, for example, or may stand on a sharp object and don't even feel it, and then it leads to an open wound, and it leads to something in the majority of cases called osteomyelitis, which pardon me, is a nasty bone disease. You are on antibiotics and in the hospital for about 8 weeks minimum. It's not a good thing to do. And diabetic foot, for anyone who's worked in a hospital, I worked on a diabetic ward for about 3 months. Didn't do that long on diabetes actually. You can tell when someone's got a diabetic foot infection. It hits the back of your throat. It is not a nice smell. So nerve, cardiovascular disease, eye, kidney. What am I missing here? Am I missing anything? Because they're categorised in macrovascular and microvascular. I'm trying to think if there's anything else. Anyway, they're the main ones, but I do not have any increased risk of any of these at this moment in time. However, if I were to go off the rails with diet, lifestyle, not exercise, all these things, my risk of going into full-blown type 2 diabetes is a lot higher than the average person in the population. So that's my metabolic health. In terms of other history, so everyone on my dad's side of the family has had a heart attack on the male side before the age of 50. My dad was no exception. He was 50 and 51 when he had his two. I then done a genetic test, which I will do. I think I've done a video on this, but the genetic test had something called lipoprotein little a. Now, if this is high, I'm trying to explain this without going too much into it. If you were here before and I discussed LDL cholesterol, which is known as the bad cholesterol, it's not. But on every LDL cholesterol, you will have a little marker, and it basically tells the body that this is an LDL particle, and that is LDL. Now, on some of them, you will have a little marker called apoprotein little a, and this makes this particle even worse. So essentially it covers it with like snow chains, and when that's going through the blood vessel, it will pick anything up, and when it gets lodged into here, it's got more things attached to it. It's like phospholipids. It makes it more of a chance that it's going to cause this process here to build out a plaque, which is not ideal. Now, I got this tested through obviously myself, just to make sure that I didn't have this risk, because everyone seems to have a heart attack in my dad's family. Turned out that my level was greater than 240 nanomoles per litre. What we aim for is less than 30. So mine could be 500, it could be even more. But basically, this and above is present in less than 1% of the population. So being at this level compared to there, I'm about, I think it's 3.5 to 4 times more likely to have a heart attack. Not ideal. When you couple that with the diabetes, it puts me in a very high risk group. So that is why I obviously take a lot of care with what I eat, how I exercise, and a lot of other things, and try and look into it. From a cancer point of view, so I'm obviously probably boring a lot of people now with my history. Mum's still alive, thankfully, but my nan passed away with bowel cancer. My mum had cancer at 23. Everyone's had cancer on my mum's side of the family. Her brother, he had bladder cancer, I think at 50-ish. Everyone seems to have cancer, and you can develop, or you can be at risk of something called Lynch syndrome. So I actually need to go and get tested for this. If you've got a lot of cancers within the family, go and get tested for something called Lynch syndrome, because it gives you an idea of, do you carry a gene which is more predisposing to bowel cancers and other types of awful cancers. Not that anyone's good, but you can go and have a look at that. So my risk deep down is probably quite high, which is why I will have a quick look in a second what people are asking. But I'm going to do a video because the month, well, April is known for bowel cancer awareness. One second. So, bowel cancer awareness month. Now, like I said, my nan passed away at 66 with bowel cancer, really bad. Her mum also had bowel cancer, I believe. A lot of other people in the family have had it. And in 2019, the UK changed its testing for the national screening to a more accurate one, because my nan had hers in 2005. She had the test at the time and it come up as negative, which does happen. There's something called a false negative. But since then, we've become more aware of it. We've updated the testing procedure, and I'm going to go into it because I'm doing a video on it, because I feel like bowel cancer is, it's not a glamorous subject. Obviously, it talks about obviously going to the toilet, having stools, poo, all them things. It's not a very, very dignifying process. However, if you catch it very early, as with most cancers, but bowel cancer is a big one, if you catch it early, there's a good chance that you'll have a good quality of life after it. So I'm going to go into that quickly, because I'm going to do a full video. I've got a fit test, actually. I've done one myself a couple of years ago, because I had a positive fit test. Ended up having a colonoscopy, which just showed inflammation, which was obviously good for me. But I want to show people how to do it. Obviously not the whole process, but have a good idea, remove the stigma from it, and get people tested, because it's always worth getting it done, in my opinion. And it's all in the privacy of your own home now. So, bowel cancer. It is, top of my head, I think it's the third leading cause of cancer deaths within the UK, I think globally as well. Not ideal. We first see, we start screening for bowel cancer once you get to about 50 in the UK. I think in the US it is 45, they changed it. And you will get something called a FIT test, which is a fecal immunochemical test. Basically, you will have a poo on a piece of tissue. So let's say this is a bird's eye view of the toilet. You will have tissue going across. You obviously go to the toilet there. It's not as bad as it seems. You will then have like a cotton bud type thing. You will put it into the sample. You will then put it back into a test tube. You put it back into the envelope, and you send that off, and it will normally take 1 to 2 weeks. Now, years ago, when my nan done it, so this is all before 2019, it was mainly based on like a sensitivity. It would come back with a gradient. So it was, if you've ever done a urine sample and it comes back with a colour, and it's like, is it pink, is it purple? Don't know. Now you come back with a numerical value. And once a numerical value comes back, let's say in this case it's above 10. If it's 10 plus, you will then be seeing, because it means that there may be some blood within that sample, because it is on a very, very microscopic level. Now, if it comes back as positive, like mine did, don't be worried, because there's so many things that can cause blood within the stool. So you can have a general intolerance. So you've got intolerance, you have IBS, you have stress, which is actually the cause of mine. You obviously can have inflammatory bowel disease, you can have cancer, you can have piles. So they're main causes of it. And if there is no conceivable cause that we can see at the appointment, we can then send you for a colonoscopy. I went for that. You get sedated, you get fentanyl and midazolam, and the whole process goes pretty smoothly. And at the end of it, you can have a biopsy, which I think I ended up having a biopsy. Mine saying that's okay. And that's it. But with the testing, it is definitely worth it. Now, you will get things such as false negatives and positives. However, the occurrence of these in the new testing is a lot lower than what it was previously. And a false negative is where it comes out negative and it should be positive, and a false positive is where it comes out saying you've got something when in reality you haven't. And that is the luck of the draw. But on a mass population level, it saves more lives than what it causes harm, which is what is it's a determining factor for any national screening program. That's why prostate doesn't have a national screening program for men, because you can do a blood test and you can have a normal prostate level, but you can have really advanced cancer. You can also have really high prostate levels but just have a benign growth. So a lot of people were finding it was more harmful to have a biopsy and have invasive procedures when a lot of people didn't have prostate cancer. So that is why it's a struggle for men. Obviously breast cancer has it, endometrial, cervical cancer. But I'm going to look if there's any questions. So let me have a quick look. So serious diabetes can cause addressing the lifespan thing, it's very, very, how do you put it? It's quite elusive, but if you actually look on NICE, when you go on the diabetes guideline, I cannot think what number it is, but when you go on there, it will say despite effective treatments, it can reduce your lifespan up to 10 years. And the reason being, in my opinion, is because, like I said before, type 1 diabetes is a bit awkward, because type 1 diabetes is where you've had an autoimmune destruction of your pancreas, so there's not much you can really do. There's things you can do to alleviate your diabetes, but there's not much you can do in the sense that it was from birth in a large majority of cases. With type 2, however, like I said, if you're giving insulin and there's a muscle cell and you're trying to put more sugar into there and you've got loads of fat and sugar in there, it's just merely making this level low so that it looks good, but you're not solving the root cause. So if I said to you, oh well, you look healthy, let's go for a run, let's go and do a little jog, because your body is not able to use energy appropriately, which is a large majority of the causes of insulin resistance, is the inability to use fuels for energy, then obviously you can't run and do them things. So over time, you just reduce your fitness and stamina because you're just merely masking a symptom. Whereas if we approached it from a lifestyle diet point of view, along with medication, that's when you'll get a better return. Let me have a look at these other questions. Right, so to be fair, my doctor is morbidly obese. Yeah. Long term. Okay, that's obviously, it's always good to work on it. Immediately. I done a fit test and it was all clear. That's very good. Is that why my dad had pancreatic cancer, because of type 1? So I'll go through a few things. So obviously, like I've said before, it's always good to look after all aspects of your health, physical, mental, spiritual, all these things. It doesn't just, eating a nice meal or a healthy meal all the time is not going to be the saviour to anything if you don't do exercise, if you don't exercise mindfulness. So you need to give yourself time in the day to relax, and there's a lot of things that come into a healthy system, and health is just ever growing as a very complex area. With regards to pancreatic cancer, it's a very tough one. Pancreatic cancer is in that bracket where it is unfortunately very, very severe when a patient has it. I would say pancreatic cancer, esophageal, what else would I say is really severe? Bladder cancer, if you don't catch it, again, all these are if you don't catch it early enough. But with the difference between type 1 and type 2 diabetes, I think it's good if I go through it. So type 1 is normally from birth. However, I had a patient last week who was 41 and they were diagnosed with type 1 diabetes, and people think, how can that be? So basically, you've got your pancreas, which is always a funny shape. It's like that. So your pancreas has, it's got two main cells. So you've got alpha and you've got beta. Now the pancreas does many functions, so it's got these cells. Also has things called exocrine glands. I haven't done pancreatic physiology for a while, but it connects through the common bile duct and it releases all things such as amylases, peptidases. So when you have a meal, it releases all these enzymes. So these are like, if you want to think of an enzyme as like a scissor, pair of scissors, it cuts up all foods, it makes the reaction more possible. So if you ever have any issues with your pancreas or pancreatitis, you need to go on medications that can help you digest food, because a lot of things come from your pancreas to help you digest in the intestine. So you've got them things, right? But with regards to diabetes, you've got two different cells. So alpha cells, these release a hormone called glucagon, if I can spell today. And then the beta cells release insulin. Obviously there are other cells in here. There's delta, which release somatostatin, which affect different parts of your hypothalamus, pituitary axis, blah blah blah. But outside the scope of this, insulin and glucagon, they're the main ones. Now, in someone who's got type 1 diabetes, you've probably heard of something called autoimmune conditions. So basically, you will have a cell, this is in general, it will have a thing on it called an antigen. So something on the membrane where it recognises it as being a liver cell, a bone cell, a muscle cell. And normally your body should leave that. It shouldn't really attack it. However, if a bacteria comes in and it's got a cell on here, another antigen, your body will say, well actually, I'm going to attack that with an antibody, or I'm going to attack it with an immune cell. Get rid of that. However, when this goes wrong, your body attacks its own cells. So what's happening with type 1 diabetes is that for some reason, the beta cells, which produce insulin, are being attacked by the body. So if you decrease the amount of beta cells, you will decrease the amount of insulin. Now, in a lot of patients, that normally happens, I would say by the age of 10, you will have full-blown type 1 diabetes. However, if the destruction is more progressive, you can have it like my patient last week who was 41. Now, with treatment with that, you obviously give insulin. But with regards to the cancer, because your body is being attacked, cancer is, in the simplest form, it's a unregulated growth of the body. And when you've got a lot of toxins being released because they're being attacked, you can then have a lot of growths happening within the pancreas. You can get extra blood supplies, which is called angiogenesis. And that is probably the reason why you would develop pancreatic cancer. It's not the main reason, but it's obviously a big offending factor, is that the body is already attacking itself. Just for completeness, glucagon, these two are hormones that work in conjunction with each other. So think of them as a dial. So think of them as a dial. So when insulin is high, glucagon is low. Because glucagon, what it does is it releases sugar from the liver from the liver and muscle cells, and this is usually in between a meal. So if you are eating all the time, this is always high, like here, and you'll have low glucagon. However, when you fast, you will have high levels of glucagon, low levels of insulin, and then it will start using up any storage of anything within your body. Right, so that's a bit of completeness. I haven't looked at pancreatic physiology for years. I can tell you how insulin's released though. I obviously know that process. Right, I'll look at any questions. I thought I needed to do this, lads, to sort of get me back into doing. Right. Let me see what else there is. He died age 83, 2 years. That's a good age. How are you? Yes, that's good. What's the main cause? Is it possible to have genetics? It's caught early. So a few questions. With a lot of cancers, it's like a crystal ball. You can never tell how early someone is going, how long someone's going to live. And normally cancers, if you ever look at survival, it's always based on a 5-year survival, and it will give you a percentage. It might be like 20% of people survive at 5 years, so meaning that 4 out of the 5 people will sadly have passed away within that time period. With all cancers, it's the same with anything in life. If you stop it as early on as you can, you're going to get the best outcomes. If your bath's overflowing, you're going to have a better chance of saving the rest of your house by turning it off as soon as it starts to overflow, as opposed to leaving it for a while, because on the surface it may look like, oh, it's only gone into this room, however it could have gone into all the other floorboards. That is the same with anything. So pancreatic cancer, yeah, I would say potentially it is true, especially now. There's a lot more, there's ways in which you treat cancer. So there's radiotherapy, which is just basically, we can treat cancer as a large scale of it. If you just went in and actually bleached and destroyed every single cell in the body, you would treat the cancer. However, you would also kill yourself because you have removed all the cells that are making you live. But cancer therapy has evolved so much because we have targeted chemotherapy now, where we're looking at certain ways in which cancer cells are growing, and they express, like I said, they express them little molecules on the surface, and we say, well, in breast cancer they have these, let's use this type of therapy. And the benefit of that is that you're destroying the cancer cells without affecting your normal cells as much as possible, which is a big bonus in comparison to years ago. We're better at detecting cancers, but it's always a balance. Do you want to detect them and have treatment, or do some people just want to live and carry on what's happening? Now, with the diabetes, I'm going to check that one and check that question again, and I will look at that James Wright's question as well. So, what is the main cause of diabetes in young men in 30s? Is it possible without genetics? Extremely rare, most people get it. I mean, if you look back years ago, you would never have really seen childhood obesity. And like I said, type 2 diabetes for people in the 30s, I'm seeing more and more people get diabetes in their 20s and 30s now than I've ever seen. And that's, like I've said, if you are not able to use the sugar or energy in your food, it goes to fat. The fat goes into the muscle cell. This is fat. Your mitochondria, because you are either eating too much and not exercising, is not able to use that fat, so it just stores it, keeps it there. When you've got too much fat, there's an insulin receptor. When you've got too much fat, it blocks the pathway of insulin, which obviously stops it then from allowing glucose to come into the cell. And then over time, you release more insulin, you make more fat, it goes into an absolute vicious cycle like this. It is never ending until you go on insulin or whatever it is, go on some form of treatment, and then it looks okay. So your blood work comes back. So you may be familiar of a blood test called HbA1c, which is glycated hemoglobin. So sugar can bind to red blood cells, and the reason we use that is because your red blood cells normally have a lifespan of 120 days. So it gives us a good marker that if the blood's got this much sugar attached to it within the last 4 months, that is what you've been averaging for your levels. So, pardon me, that is why a lot more people are getting it earlier on, is because they're developing this insulin resistance, metabolically unfit, and it's more common than it's ever been. Now I'm going to go and answer James's question because, pardon me. How worried would you be about a long-term use of omeprazole over 15 years? Well, okay. I was actually going to discuss omeprazole because I think I was saying before, it is, I think, the second or third most prescribed drug within the UK. It is massive. And if people actually understood what it was, how it works, and how you should use it best, then I think there would be a lot of things that are improving. So, for context, with all medication, it's all about using the lowest effective dose. So with omeprazole, the lowest dose that you can get for adults is 10 milligrams each day. So if you've had 10 milligrams each day for 15 years, it's going to be a lot better than you having 40 milligrams each day for 15 years. However, for context, I would say about 60% of patients that I review on a daily basis have been on a proton pump inhibitor, so omeprazole, pantoprazole, lansoprazole, at least 20 milligrams each day for at least 25 years, and nothing serious has happened. But a lot of these people don't need to be on it. So you've got omeprazole. I'm just going to write it so it's easy to see. Omeprazole, lansoprazole. I'm not going to write pantoprazole. They all belong to a class of medication called proton pump inhibitors, always shortened to PPIs. The way they work is within your stomach. So imagine this is your stomach. You have your esophagus and you've got your intestine. So food goes that way and it comes in this way. Right, now when you have food coming in, your stomach acid normally is, let's say it's that level, your stomach acid normally has a pH of around, this has got me now, I want to say it's 1 to 3. It's similar to hydrochloric acid. If you remember chemistry in school, you used to have hydrochloric acid for certain reactions. So it is very, very acidic because neutral is 7, and that's like most water sits around 7.35, don't they? Right, so it's very acidic. The reason being is that it allows you to break up a lot of food, a lot of things dissolve within acids. Now, in people who need PPIs, what the issue is that a lot of this acid is going up through the esophagus, and why that's an issue is that within your stomach, your cells look like this. They are very, very tight, called tight junctions, whereas in here, in your esophagus and most of it, you will have them with maybe tiny little gaps, not as protective. So what happens is that the other parts of the body are more susceptible to the acid, and also on top of these cells you have something called the mucous membrane, which also protects the stomach from irritation. Now, the reason why people go on these is for a couple of reasons. You've got a valve here, a sphincter, lower esophageal sphincter. If you have a lot of alcohol, you smoke, you are overweight, you have a lot of spicy foods or ultra processed foods, increases the amount of acid, reduces the tone of this, and basically you have more acid going up there. Now these are produced by, what cell is it? I think they're called the parietal cell. Anyway, there's a transporter within your stomach. It is called, for completeness, the hydrogen potassium ATPase. Basically, it pumps out acid into your stomach to make the hydrochloric acid. What these do are, it stops that from working. And it doesn't just stop them, it stops them from the point of view that if your body wants to make more acid in the stomach, it completely removes that pump from working, and the body needs to make another one. Whereas most medication would just block it, and then if it's stopped, it can reuse that transporter. You need to make a new transporter. So that's like general overview. So we obviously need acid to break a lot of things down. A lot of things that have come from the use of PPIs long term. So the one thing I will need to say is that these are classed as associations. They are not causations at the moment. What that means is, it's like saying everyone from London, if you live in London, no, let me phrase this differently. So everyone from London has a Ferrari. So if it's an association, that's what it means, is that people who live in London tend to have a Ferrari. But it doesn't mean if you live in London, you will get a Ferrari. Same way, everyone or a lot of people who use PPIs have the following complications. However, it doesn't categorically mean that you will develop them. The biggest risks or biggest things that happen: low B12. We normally need acid to break up the complex. It normally helps intrinsic factor work. So that's one. Low magnesium. A lot of people are on magnesium supplements to help them sleep. If you're on a proton pump inhibitor and have poor sleep, could be because you've got low magnesium. We have increased risk of osteoporosis, and that is due to the fact that we are absorbing less calcium. So it's believed that we need an acidic environment for calcium. You have an increased risk in pneumonia, community acquired pneumonia. You also have an increased risk of something called Clostridium difficile, which is a bacterial infection of the gut. So these are all, and then you've got the big one, sorry I nearly missed it, which is increased risk of dementia. So these are all associations at the moment. Largely, I believe B12 and magnesium are pretty much a causation. Osteoporosis, I would say, is more of a causation. The ones with the latter end dementia, just because the sheer amount of people are on PPIs, I feel like it's hard to find, is that a true cause or not? So in terms of long-term risk, would I be worried? From what I've seen, no. My advice, again, this is not medical advice, but my thing would always be on the lowest effective dose of every medication you can be on, because it's always interacting with something to correct something. So in this case, it's stopping your body producing acid, which can lead to potentially all them risks before. So if you can reduce the need for it, it's always better. And the only thing is you need to ask yourself in the first reason, why are you on this medication? Is it because you've got a lot of lifestyle issues, or is it because you've got something underlying? Do you have a gastric cancer? Do you have something else, H. pylori, which is an infection, which also causes you to have high levels of acid? Do you have something called Zollinger-Ellison syndrome, which is hypersecretion of acid? You need to know what that reason is first before you take it long term. That would always be my point of view on it. But they are highly effective. And one thing that a lot of people forget is, because your body needs to make new ones of these, if you stop all the proton pump inhibitors cold turkey, your body will upregulate them more than they've ever been, and you can get rebound reflux, and then people feel 10 times worse than when they were previously started on it. So the best way to ever come off these medications is to taper it. So if you're on 20 milligrams, you do 20 one day, 10 the next day for maybe 2 weeks. You can do 10 milligrams for 1 week, and then you could probably stop it. That's probably overkill, but I would always err on the side of caution. Right, let me see what questions are that. Thanks for the in-depth. I'd really surgery to come off the omeprazole. Okay, so I'll answer the cholesterol one now. What does a PPI do? So I've done that one. Melatonin. SSRIs when... So yeah, PPIs, like I said, I see a lot of patients on them every day. They just, for the other question before, they basically stop your body from producing acid, which reduces the side of, or the conditions such as high amounts of reflux. So they do work, they're highly effective, which is why it's very hard to get patients to come off them, because a lot of it, I'm not saying all of it, a lot of it is due to poor lifestyle, and a lot of people just find it easier to take the tablet as opposed to amend their lifestyle. Now, there was a question about SSRIs, which I will quickly look at again. Lowest dose, what about SSRIs? The lowest dose, like I said before, that's all individual. If the lowest dose that works for you is, let's say 60 milligrams or something, then that's the lowest dose for you. But it would always be try and get to the lowest dose that you can still feel a benefit from, because it will always reduce your chance of risks associated with medication. So don't take that as you need to get to the lowest dose that is in the product. So like as I said, the omeprazole is 10 milligrams. If 20 milligrams is the lowest you can go to before it starts to affect your quality of life, then you've got to weigh that up between you and your prescriber. Is 20 milligrams each day going to give you a greater quality of life, despite there being a higher risk of side effects, over you going to a lower one with no side effect risk but poor quality of life? Everything's a balance in life, so that's what I would say. Cholesterol, I went through a bit before, but I'll touch upon it because I'm going to do this as a video tomorrow if my voice and nose improve. Oh, wow. So cholesterol, we have got, this is based on your blood levels. So your blood levels are made up from two sources. So 20% of it comes from your diet, 80% of it comes from you making it in your body. And they're all impacted by genetics. So genetics are a big thing. However, you can modify a lot of this through lifestyle. So through diet, have early meals. These are very, very simplified. Early meals, have more fibre, have, what from meals? Reduce carbohydrates and saturated fats, obviously in response to your energy requirements. If you are running marathons, obviously you are going to need a lot more carbohydrates. Do not stop it, because you will suffer greatly on a marathon. So that's that one. What else is there from? Right, 80% from your production yourself is, so improve your muscle mass, because that will increase insulin sensitivity. You've got, what else can I do that is more diet related? I mean, these basically seesaw between each other. If you've got a lack of absorption, you will have a tiny increase in production. However, they do eventually balance out. A lot of it is due to lifestyle. A lot of it can be due to genetics as well. So if your body doesn't want to clear it from the blood, then you will have a few issues going forward. However, it's not the be all and end all, and you've got to take it into context with everything else. So the videos that I've got coming up are how does statins work in that process in terms of production from acetyl-CoA through to cholesterol, and then where do a lot of the side effects come from with statins, so muscle pain being one of them. So I'll go through that, and then from that video we can stem into lifestyle, we can do absorption, we can do insulin resistance. I'm going to do one on, what else am I doing one? Something to do with diabetes, prevention of heart attacks. Blood pressure is a massive one. Blood pressure is huge. It's probably the most underutilized or underappreciated thing when it comes to health and medicine. I'll probably do a few more minutes because my phone is literally on the last. So is PPI for acid reflux mainly? Is there any risk for taking SSRI? So what was it? Are there any risks with SSRI? So are there any risks with SSRIs? Of course, there's always risks with medication. The biggest one for SSRIs that I can think of are the risk of serotonin syndrome. So the way SSRIs are proclaimed to work, even though I think there's still a consensus that a lot of people don't know how they work. In your brain, you have one nerve going into another. So this is the travel direction. This is in your brain. Now, you will have serotonin, you will have other chemicals, noradrenaline, you will have dopamine, all these things anyway. They are released into this space. The idea is that they will then attach to little receptors here. Once they attach, they then send the signal all the way down and get that to be released at the other end, which is down here. And obviously that conforms to a normal brain function, if you want to say it like that. However, SSRIs, when you've got a lot of serotonin in this bit, if it's not being captured by this receptor, the body will reuptake it and bring it back into here. So SSRIs prevent the reuptake of it. So they are called selective serotonin reuptake inhibitors, and that's basically what it means. So they are preventing it from coming out of here into here, and that means that more stay within this synaptic cleft, meaning that you've got a higher interaction with the receptor on the next nerve. That is basically how they are proposed to have worked. Now, if you've got a lot of serotonin, you can develop something called serotonin syndrome. Very rare. I think I've seen it twice in all the years I've worked in hospital and healthcare. Serotonin syndrome is normally characterized by irritability, change, very sensitive to temperature changes, and eventually can lead to seizures. So that is the biggest risk when it comes to that. Next thing about OTC supplements that affect cholesterol that actually work. Now, I actually wouldn't advise a lot of OTC supplements. One, they're not regulated, and two, we are not able to determine whether they're going to be fully safe for you. And the reason being is that 20% of the population, when it comes to cholesterol, are called hyper-absorbers. What that means is that when it comes to the intestine, so you've got the intestine cell there, you've got your body, so your blood, and you've got your gastrointestinal tract here. There's a transporter here, which I told you before, Niemann-Pick C1 like one. If you are a hyperabsorber, you will absorb anything through there, absolutely anything that is looking like a cholesterol. And this includes plant sterols as well, which are not good for the body because we normally get rid of at least 95% of them. If you are absorbing a lot and you've just given someone a plant sterol, there's a good chance that they are going to have more plant sterols be absorbed into the body. And because they are similar in structure to cholesterol, but they are not the same, they can cause dysfunction with cell membranes, so they're not the best. So you need to know whether this is really active on someone. There is a test in America, we don't offer it in the UK. It's called the Boston Heart Health. You can look at it. Boston Heart Health. And it basically measures two things, measures four things, but two large things. It measures how much plant sterols are within your blood. So it normally goes for beta cytosterol. If this is high, it means you are absorbing a lot. It then looks at the natural production of cholesterol in the body. So it looks at lithosterol and desmosterol. So if these are high, it means you're a hypersynthesizer, but if they are low, it means you are mainly getting it from your diet. So by getting something that's over the counter, which is a plant sterol, you could actually be causing a harm to at least 1 in 5 patients. So it's important that you know what type you are before you take it. And that is why, I don't actually know whether it's why, but that's why we don't advise plant sterols over the counter anymore. Because I'm hoping it's due to this. I don't think it is. It's just probably because there's no evidence on it, or not many studies within the UK. Pardon me. Right, let's see if there's any more questions. I think. Do I prescribe them, do I think? Okay. Do I prescribe SSRIs? Technically yes, but I don't start people on them. I leave that for the GPs or the clinics mainly. Just because I try and optimise lifestyle through other things. But when it comes to, you just said omega-3 then. So I actually do have an omega-3 supplement. And I'll be honest, I actually don't really take it. But it's this one. Now, there was an issue with omega-3 when it comes to heart arrhythmias, which I'll go through in a minute. But omega-3, you can get it mainly from fish, so fish oils, whatever. However, if you are vegan, you can get it from algae, and it's got a high source of it. And the thing about omega-3, which is why a lot of people supplement it, or why it's a big thing. So omega-3, pardon me. Wow. So omega-3 is a type of fat where it's called an omega-3 because its double bond is on the omega and 3 carbons in, whatever. The issue with omega-3 is that the body cannot produce any. So it means that we must get it from our diet. So with omega-3, like I said, it comes from fish, and it comes from algae. They're like the main ones. Now, the consensus was years ago, if you have oily fish, so these are mackerel, you've got salmon, you've got sardines. If you have that about 2 to 3 times a week, that should be enough. Algae, I actually don't know how much you should have of that from your diet. Anyway, something I need to look up. But if you have enough of that, then it should give you enough. However, given recent fish farming and a few other things, even myself, I done a test where I found out that I actually had low levels of omega-3 despite having a high level within my diet. So technically you should supplement it. The hardest thing with supplements, like I said, they are not regulated, so there are certain manufacturers who may not have the same amount that you want to have in them, and there's no real legislation around it. The only way around it is if you can get companies that you trust, and then you can get blood testing around it. So the issue with omega-3s that come to light was there were some synthetic ones, and it was called, it was like ISA, I actually can't think of the actual term, but we could prescribe it essentially. And the issue with it was that it was increasing, not this, but it was increasing the risk of something called AF, which is atrial fibrillation. So it actually has stopped really being used, the pharmaceutical grade stuff, because it was leading to an increase in this. What this is, it's actually becoming very common within young men now. Whether it's due to illicit drug use, whether it's due to excessive caffeine or stress within the world, I don't know. Obviously I can't say. But atrial fibrillation is, if this is your heart, you have 1, 2, 3, 4. So you have your heartbeat starts there. It will eventually contract these two. So these are your atria. Sends the blood down into your ventricles, and then depending on where it needs to go, if it's going from here, it will go to your lung, and if it's here, it will go through your aorta. Now, in atrial fibrillation, these two start quivering like this. When they quiver, they can't contract any blood, the blood can't go down there. So the issue is that the blood stays in here, stays in the atria. If you have blood sitting for a long time, same way if you cut yourself, and you don't wipe it away, you'll find that it has a little clot, and that's the issue, is that it forms little clots, and if it goes off to the lung, you get a pulmonary embolism, and if it goes through the aorta, you can have a stroke. So that is why a lot of people don't use the pharmaceutical grade stuff, because it was increasing atrial fibrillation. If you have that condition, you go on to normally beta blocker. I know this is a bit off topic, but beta blocker, and you go on anticoagulant to reduce this. Right, I'll see if there's any more questions, and then I will have to probably end this live because my phone is going to die. So I don't want that to happen. I'm surprised I've been able to speak this long. I need to really blow my nose after this. I'm bunged up to the max. Let's see. Yeah. EPA, do you think what's a good level? So EPA, DHA, different forms. So with omega-3, testing me today because I haven't actually looked at omega-3 for a while. You've got, for omega-3, if I watch this back and I get it wrong, it's going to be funny. But you've got ALA, you have EPA, and you have DHA. ALA comes from plants, it's like normal plant food. However, the conversion to EPA is very low. So that is why we normally just go straight for EPA and DHA. Now, I probably aim for, I'm going to actually look. What do I get if I take that? I aim for about, of them two combined for my weight, about 1.5 to 2 grams. So it isn't a very high end of it. However, like I said before, if you are more predisposed to having irregular heart rhythms, then you wouldn't go as high as that. But these are just more in readily available forms. This one comes from more plant-based sources, however, doesn't have a good conversion to these because these two can convert between themselves essentially. But yeah, that's the thing with omega-3. I actually probably need to start looking into it a bit more. I was taking it a bit more. And the last thing I will end on is, why do my lives get blocked after I do them? And the honest answer was, I didn't want the channel to be blocked up with a lot of lives because I didn't really have any plan with them, no substance with them. Whereas this one today, actually, I will probably keep it as a live and let it go up because I actually didn't think it was that bad, to be honest, if I do say so myself. So stuff like this I'll keep up, but the other ones where it's just general me sitting down maybe before I go to bed, that wasn't an option. The reason I didn't do YouTube for a long time is because I was waiting for some scrubs, which I've now got. I was meant to film today, however, as you can probably hear, my voice is not the best. I'm congested, so it's probably not the best time to do it because I'll be coughing all the time. But I'm going to be doing more pharmaceutical videos like that with scrubs on, with a whiteboard, because it just seems more relatable. People can see stuff. I'll have it more pre-planned, written out, and then I'll try and do lives a bit more frequently now that I know I've got something where I can keep and put up. So I'll have a quick check if there are any questions. Yeah, no more questions. But yeah, like I said, I'll try and do them more frequently. I'm going to start using it a bit more. Thanks very much for watching. I'm going to go and get ready for the rest of the day. And next week I'll have a couple of videos on cholesterol put up, and I'll probably have 1 or 2 lives anyway. So thanks very much, and have a good rest of your weekend, and see you soon.